Good morning, everyone. Today we'll be continuing our class on lymphomas. In the previous class, we were talking about Hodgkin's lymphoma and we'll continue the class. We have already discussed the WHO classification of lymphoid neoplasms. A brief review. According to WHO classification, lymphoid neoplasms are classified under precursor B cell neoplasms, which include precursor B lymphoblastic leukemia or lymphoma, and peripheral B cell neoplasms, which include chronic lymphocytic lymphoma and small lymphocytic lymphoma or chronic lymphocytic leukemia, lymphoplasmacytic leukemia, mantle cell lymphoma, follicular lymphoma, marginal zone lymphoma, hairy cell leukemia, plasmacytoma or plasma cell myeloma, diffuse large B cell lymphoma, Burkitt lymphoma. Under precursor T cell neoplasms, precursor T lymphoblastic leukemia or lymphoma, and a peripheral T cell and natural killer cell neoplasms, T cell pro-lymphocytic leukemia, mycosis fungoides Sézary syndrome, peripheral T cell lymphoma unspecified, anaplastic large cell lymphoma, angioimmunoblastic T cell lymphoma, adult T cell leukemia or lymphoma, and enteropathy associated T cell lymphomas or myeloma. Large cell granular lymphocytic leukemia, natural killer cell and T cell lymphoma nasal type, natural killer cell leukemia, panicleitis like T cell lymphoma, hepatosplenomegaly, gamma or delta T cell lymphoma, and under Hodgkin's lymphoma, classical Hodgkin's, nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion, and lymphocyte predominance. These are the lymphoid neoplasms according to WHO classification. As we said, lymphoid neoplasms are broadly categorized into leukemias and lymphomas are further classified as Hodgkin's and non-Hodgkin's. In the previous class, already we have discussed about Hodgkin's lymphoma. Today, we'll be discussing about non-Hodgkin's lymphoma. The incidence of non-Hodgkin's lymphoma is increasing day by day in the United States of America. This became the sixth most leading cause of cancer death. It affects all the age groups, but incidence increases with age. Non-Hodgkin's lymphoma primarily affects lymph nodes. Almost 2/3 of the cases arises in lymph node and 1/3 of the cases arises in the lymphoid tissue of parenchymal organs, that is extranodal lymphoidal tissues like gastrointestinal tract. They often have bone marrow involvement. There are various classifications of non-Hodgkin's lymphoma based on histological pattern, morphology of lymphoma, T cells and B cell type. Nodular or follicular pattern of non-Hodgkin's lymphoma and small cells with mature chromatin pattern behave indolently, while large cells with fine chromatin they behave aggressively. Non-Hodgkin's lymphoma can arise both from B cells and T cells. About 85% of all the non-Hodgkin's lymphomas are B cell in origin, while 15% of non-Hodgkin's lymphomas are T cell in origin. Tumors of histiocytes or macrophages are very uncommon. The B cell non-Hodgkin's lymphomas show expression for CD19, CD20, surface immunoglobulins, and CD10, also called as color antigen. While the T cell non-Hodgkin lymphoma show positivity for CD2, CD3, CD4, CD7, and CD8. According to working formulation, non-Hodgkin's lymphoma is divided for clinical purpose into low grade, intermediate grade, and high grade. Under low grade, it includes small lymphocytic leukemia, follicular lymphoma, predominantly small cleavage cell, follicular lymphoma containing mixed small cleavage and large cell lymphomas. Under intermediate grade, follicular lymphoma predominantly large cell type and diffuse, showing small cleavage cells, diffused, mixed small and large cell, diffuse large cell lymphomas. Under high grade, large cell immunoblastic lymphoma, lymphoblastic lymphoma, and small non-cleavage cell lymphoma are seen. The indolent type of non-Hodgkin's lymphoma has a long history, but they are not curable. But the aggressive types of non-Hodgkin's lymphoma have a rapid clinical progression, but they may be cured by chemotherapy. Accordingly, The non-Hodgkin's lymphoma are classified as indolent types and aggressive types. Under indolent types, the non-Hodgkin's lymphoma variants seen are small lymphocytic lymphoma, follicular center lymphoma, mantle cell lymphoma, mucosa-associated lymphoma or marginal zone B-cell lymphoma, mycosis fungoides or Sézary syndrome. Under aggressive types of non-Hodgkin's lymphoma, diffuse large B-cell lymphoma, peripheral T-cell lymphoma, Burkitt's lymphoma, precursor B of T lymphoblastic leukemia or lymphoma, anaplastic large cell lymphoma are included. Now we will be dealing with few common variants of non-Hodgkin lymphoma. Follicular lymphoma. This is the most common form of indolent non-Hodgkin's lymphoma. This arises from the B cells. This lymphoma mimics a normal lymphoid follicle in pattern and cytology. This type of lymphoma is most common in European countries and North America. They affect adults of more than 40 years of age and they present usually in the high stage. Males and females are equally affected. This neoplasm arises from the germinal center of the B cells. They show strong association with translocations involving BCL2. The hallmark translocation seen in follicular lymphoma is translocation 14-18, which shows fusion of IgH locus on chromosome 14 with BCL2 gene on chromosome 18. BCL2 gene is a protein that inhibits apoptosis, hence, these cells attain immortality, turning into leukemic cells. Microscopy of follicular lymphoma shows small cleavage cells with irregular or cleaved nuclear contours and scant cytoplasm. Immunohistochemically, all the follicular lymphomas are positive for monoclonal surface immunoglobulins and pan B-cell antigens like CD19, CD20, CD10. These patients present with painless generalized lymphadenopathy. They usually are indolent in behavior, but these tumors are incurable. The median survival rate for follicular lymphoma is 7 to 9 years. 30 to 50% of follicular lymphomas undergo transformation into diffuse large B-cell lymphomas, that is the aggressive form of lymphoma. This is the microscopic picture of follicular lymphoma mimicking a normal lymphoid tissue showing germinal centers. This is a hyperview showing follicular lymphoma cells showing a small cleaved cells. This is the karyotyping picture of chromosomes showing 14 and 18 translocations. This is a karyotypic image showing fusion of BCL2 gene with immunoglobulin heavy chain. The next variant is diffuse large B-cell lymphoma. This is the most common non-Hodgkin's lymphoma, comprising 35%. It shows male predominance presenting at 60 years of age. There is diffuse pattern of involvement of the lymph node composed of large cells which are 4 to 5 times the diameter of the small lymphocyte. These neoplastic cells show multilobation or cleaved nuclei resembling as a Reed-Steinberg cell of Hodgkin's lymphoma. This diffuse large B-cell lymphomas show positivity for CD90, CD20, surface immunoglobulins and BCL2 protein. Diffuse large B-cell lymphoma shows two subtypes. They are immunodeficiency associated large B-cell lymphoma and primary effusion lymphomas. In immunodeficiency associated large B-cell lymphomas, the neoplastic B cells are often infected with Epstein-Barr virus. This is seen usually in conditions with severe T-cell immunodeficiency, severe combined immunodeficiency, bone marrow and solid organ transplantations. The second subtype is primary effusion lymphoma. This arises as a malignant pleural effusion or ascites. The tumor cells are anaplastic and they fail to express B or T cell markers on their surface. These tumor cells are infected with Kaposi sarcoma virus. This is the microscopic picture showing diffuse lymphoma. This is the hyper view showing the cells with a cleaved or a lobation of the nuclei. The next variant is mycosis fungoides Sézary syndrome. This is a manifestation of tumor of CD4 helper T cells at home to the skin. They present with skin lesions like erythroderma, skin plaques, skin nodules, and Potter's abscesses. Sézary syndrome is a ultimate manifestation of T cell lymphoma with erythroderma, which shows erythroderma with leukemic phase. These are low-grade tumors, but they can progress to aggressive T cell lymphomas. Clinically, they present with pre-mycotic phase, mycotic, and leukemic phase. Microscopically, the epidermis and upper dermis are infiltrated by neoplastic T cells showing cribriform nuclei. These cells are called as Sézary cells, which is characteristic of mycosis fungoides. This is a picture showing early skin lesions to the left and plaques to the right side of the image. This is the earliest presentation of mycosis fungoides. This is a microscopic picture. To the left is showing a Potter's abscess, which shows neoplastic cells within the upper dermis, and that to the right is the high power view showing Sézary cells. There is a microscopic picture of Sézary cells, which are showing cleaved nuclei, cribriform nuclei. The next variant is chronic lymphocytic leukemia or small lymphocytic lymphoma. This occurs at the median age of 60 years with a male predominance. This shows a diffuse effacement of the lymph node architecture, and the lymph node is mainly composed of small lymphocytes with slight irregular nuclei and scant cytoplasm. This lymphomas has presence with systemic symptoms like fatigue, weight loss, anorexia, generalized lymphadenopathy, hepatosplenomegaly. Most of these lymphomas has a tendency to transform into diffuse large B-cell lymphoma. About 15 to 30% of chronic lymphocytic leukemias have a tendency to transform into diffuse large B-cell lymphomas, which is called as Richard syndrome. This is a microscopic picture showing chronic lymphocytic leukemia. The next variant is mantle cell lymphoma. They comprises about 3 to 5% of non-Hodgkin's lymphoma in Western countries. They show male predominance affecting 5th to 6th decades of life. The predominant translocation seen in mantle cell lymphoma is translocation 11-14. The lymph node resembles a normal mantle zone of the normal lymph node. Microscopically, this lymphoma shows homogeneous population of small lymphocytes with round to irregular and occasionally deeply clefted nuclear contours. They present as painless lymphadenopathy and splenomegaly. There is a microscopic image showing mantle cell lymphoma. These cells are showing clefted nuclei, occasionally clefted nuclei. Marginal zone lymphoma is the other variant of non-Hodgkin's lymphoma. It can arise in lymph nodes, spleen, and extranodal sites like salivary gland, thyroid, stomach, etc. They often arise in the background of chronic inflammatory pathology, autoimmune infections, or any infectious etiology. They remain localized for prolonged periods but spread systemically in the late course of time. They may regress if the infecting agent is eradicated, like Helicobacter pylori infections. If the translocations 11, 18, or 114 are occurring within the extranodal sites, they may result in martomas. is a microscopic picture showing extranodal marginal zone lymphoma, intestinal tissue with lymphoma. There's a microscopic picture showing intestinal glands on the lymphoma. The last variant is Burkitt's lymphoma. This comprises about 30% of all childhood non-Hodgkin lymphomas. It corresponds to ALL, that is acute lymphoblastic leukemia of L3 type according to FAB classification. Microscopically, it is composed of uniform non-cleavage cells showing high mitotic activity and apoptotic tumor cells. Numerous benign macrophages with ingested nuclear debris of the tumor cells are seen microscopically, giving a starry sky appearance. This is a characteristic feature seen in the Burkitt's lymphoma, starry sky pattern. Burkitt lymphoma occurs in three forms: the African endemic type, sporadic type, HIV associated type. HIV associated is the aggressive form of Burkitt lymphoma. Histologically, all the three forms are identical, but they vary in clinical, genotypic, and virology. All these forms are associated with translocations of C myxine present over chromosome 8. All the endemic Burkitt lymphoma shows strong association with Epstein-Barr virus infections. 25% of HIV-associated tumors and 15 to 20% of sporadic Burkitt lymphoma also has association with Epstein-Barr virus infection. This is an image of the child showing African endemic type of Burkitt lymphoma presenting as a jaw tumor. This is a microscopic picture of Burkitt's lymphoma in the low power, showing diffuse involvement of the lymph node with highly cellular areas and few macrophages, giving a starry sky appearance. This is a high power view of Burkitt's lymphoma, showing small uniform cells with high mitotic activity, and few of the cells are showing apoptotic debris, ingestion of apoptotic debris. Few of the macrophages are also seen within the microscopy. This is a karyotypic image of Burkitt's lymphoma showing translocations of 8 and 14. This is a chromosomal image showing translocation of 8-14, showing a juxtaposition of C myxine with the immunoglobulin heavy chain. All the non-Hodgkin's lymphomas can be investigated through cytogenetics, immunohistochemistry, fluorescence in situ hybridization technique, and flow cytometry. The translocations involved can be detected by all these investigations, and the lymphomas can be precised and treated accordingly. This is all about non-Hodgkin's lymphoma. Thank you.